Thanks very much, Sean and Gina. Again, I'd like to thank SAGES for the opportunity to speak to you today and hopefully give you some ideas on things we can do to improve your patients' outcomes and quality in hernia repair. These are my disclosures. Of note, I do participate in a study sponsored by Intuitive. However, I enroll patients that are done in open fashion. I currently do all my abdominal wall reconstruction in open fashion as well. So as I imagine most people here know, there's a large scope of the problem. Approximately 1 million laparotomies done every year, and laparotomies often result in incisional hernias up to around 20% of the time. A recent paper by Bauckham et al. Showed, however, this can be even higher and up to around 40%, especially in those patients with abdominal malignancies. As you see by a paper here from Dr. Paulus in 2012, the incidence of incisional hernia at least increased over this time period and likely is still going up. So this is a big problem that's not going away. Despite attempts at prophylaxis, we're still having a lot of hernias to fix. So since there are so many, we better start to learn how to fix them pretty darn well. Sorry, they're expensive to treat, and there's a little mess on my slides here, but we better fix these pretty, shoot. A slide got mixed up here. All right. I apologize for that. We better fix these pretty darn well. Let me just go back and touch base on that. Some of these are also very expensive to repair. As you see, the cost from Dr. Paul's paper was up to around $16,000 back in 2006, which with the large number of yearly ventral hernia repairs being up to $350,000. That results in a total cost of about $3.2 billion in the United States every year, which means that if we could improve our outcomes enough so that we reduced our recurrence rate by about 1%, this would lead to about a $32 million savings overall. This is really important because in the United States, our healthcare expenditures are approximately 16% of our GDP, and unfortunately, within industrialized countries, this puts us at around 37th ranking in performance in terms of our expenditures. So as I was saying before, if we're going to fix hernias, we better fix them pretty darn well and improve our outcomes and give good quality to our patients. However, I don't think you can have any discussion about quality and outcomes without also discussing things such as cost, because they are intimately intertwined, especially when we look at the fact that outcome over cost, it comes out to value. This is especially important when you consider things like surgical site infections and surgical site occurrences that we want to keep low, along with recurrences are low, in order to improve our outcomes and hopefully lower costs, because as we improve these outcomes, if we do lower these negative impacting factors, the cost goes down as well. I'm sorry, this is, I don't think they've, okay, I'll apologize. This is a very old version of the talk that I don't think they updated, despite is it possible to pull in the newest version of the talk that I checked on in the speaker's ready room this morning? Do you guys have that? I just did a lot of, I changed the order of the slides so it makes a bit more sense, and this is really, should I try this newest version? Let's see. Yeah, okay, this is the right version. Thank you very much. All right, I'll try to pick up where we left off here. So we're going to advance through this quality and cost. As we said, cost is a big problem, a large problem to treat, and we can potentially save ourselves a lot of money if we decrease our recurrences. Okay. That being said, as we have seen in other talks already this morning, there are lots of ways to repair hernias. There's lots of variables that go into hernia repair, namely, where do you place the mesh? There are over 100 choices of different meshes. There's lots of ways to fixate, and you can either leave the defect open or close it down. There's also different options for myofascial release, and when you multiply all these out, it comes out to approximately 16,000 different ways of repairing a hernia. Given that this is an MIS-focused society, as well as this talk, I want to see if we can possibly improve our ventral hernia outcomes by using an MIS approach. So went straight to the literature and tried to find the most recent and updated meta-analysis that would compare these two approaches. And indeed, this is a paper from 2015. When I looked through it to summarize the results very briefly, there were no differences in hernia size, operative time, overall complications, wound complications such as SSIs or SSOs. Additionally, the hospital length of stay was the same, as was the time to return to work and recurrence rate. And I had to think sometimes when you expect to see differences in certain things, maybe the study winds up being underpowered. And as it turns out, there were only 6 studies included in this meta-analysis, including a total of 751 patients. Certainly anybody that is fairly familiar with the hernia literature knows that because we repair hernias in so many ways, we do need lots of patients. And there are certainly studies that come out of in single publications that include more patients than this one did. So I went a little further back into the literature and looked at a paper coming out of WashU back in 2007. Although this is not a meta-analysis and therefore is not strictly looking at level 1 data, i.e. randomized controlled trials, it did make up 45 studies that were included, totaling over 5,000 patients. Some of these studies were paired open and laparoscopic studies, and some were just lap ventral alone, largely retrospective. But taken all together, again, to summarize this, there was a similar operative time, but compared to the meta-analysis we saw before, there was actually a lower amount of pain and a shorter hospital stay in the patients undergoing laparoscopic ventral hernia repair. Additionally, there was a lower overall complication rate, largely due to lower rates of wound and mesh infections, and there was a lower hernia recurrence rate. So if we look at the 4 big drivers of cost in hernia repair, there is a suggestion that an MIS approach may help improve things like number 2, the hospital length of stay, number 3, the complications, and maybe the recurrence as well. But what can you as a hernia surgeon go home and do tomorrow or next week in the OR to possibly reduce your cost and therefore tip that ratio of outcomes and quality to cost? So if we look at it, of course, the easiest things that non-hernia surgeons will target are currently mesh and the robot. So let's look at the mesh. I'll give you a scenario where you're going to repair a 9-centimeter symptomatic midline hernia from a prior right colectomy. The patient goes for an open repair, and when you're in the OR, do you decide to do a laparoscopic intraperitoneal sublay using a barrier-coated mesh? Do you want to do an open retromuscular repair using a permanent synthetic, or an open retromuscular repair using a biologic or bioabsorbable? And the fact is this makes a real difference, because if you look at the cost of each of these meshes, the permanent synthetic is relatively inexpensive, and the other 2 meshes can be anywhere from 10 to 20 times the cost. So that's a definite decision you can make in the OR next week. Additionally, what about the use of the robot? Will it help out, or is it a detriment? Here I'm going to cite a study from Dr. Carbonell and others who performed a retrospective look using the America's Hernia Society Quality Collaborative, and I'll touch on that a little bit later. What they did was to compare robotic versus open retromuscular ventral hernia repairs. And first, the 2 groups were done on a propensity score matching, so patients were matched for BMI, hernia grade, wound class, diabetes, etc. And they actually did a 2-to-1 match, so that they got 220 patients in the open group down the bottom, and 111 in the robotic group. They then looked at 30-day wound outcomes as well as postoperative hospital stay. And at the wound outcomes, you see that the SSIs are roughly similar between the 2 groups. There were more surgical site occurrences in the robotic group. However, those surgical site occurrences requiring procedural intervention, or SSOPI, were about the same. This actually wasn't their primary outcome they were looking at. The primary outcome was to look at hospital length of stay, which shows a decrease from 3 days in the open group to 2 days in the robotic group. You may think, well, 1 hospital length of stay, does it really make a big difference? And I'd say that it may very well. Looking at some 2014 data, it looks like the average night for one hospital stay in one night is around $2,000. although I don't think that necessarily you can always reduce your length of stay by one night in everybody, if we go back to some of the other numbers of 150,000 inpatient ventral hernias done each year, and you could cut, if you could in theory, cut back that by 1 day each, that represents a potential savings of maybe up to $300 million. Interesting. Let's move on from cost and move up to the numerator of our equation about outcomes and our patients. There's not much level 1 data. Mostly there is some that shows that mesh reduces recurrence and laparoscopic ventral hernia may have a reduced SSI. But the real problem here is that it's very hard to follow hernia patients long term, regardless of what you want to do. You can follow them with an Excel spreadsheet, maybe an online tool such as REDCap. You could use a societal data tools such as NISQIP, or even quality assessment tools such as Hercules or the Carolinas Comfort Scale, but you shouldn't need to research study to see how your patients are doing. Just to kind of go through quickly quality of life, I think that in these patients it's probably more appropriate to use a hernia-specific QOL form, such as Hercules, which is 12 questions on a 6-point Likert scale, or the Carolinas Comfort Scale, which is 8 questions. These can take your patients all of 2 to 3 to maybe 5 minutes to fill out, and it's an easy form. You can give them anytime they come into the clinic, both before and after their operations. What about patients' recurrences? You might want to get a good idea of your recurrence rate, but you don't want to bring that patient in for an expensive CT scan or maybe even for an office visit. And as Dr. Baucom showed in 2016, you can actually ask 1 or 2 or 3 questions and get a very good idea of whether your patient has a recurrence or not. Notably, the question of do you feel your hernia has come back is the most sensitive. The specificity is not so great, but overall the best single question is do you feel or see a bulge? And honestly, if you combine these together, the power of these works out that they are more sensitive and more specific than a physical exam by a surgeon, and they actually approach the sensitivity and specificity of a CT scan. That being said, we also have a lot of other questions regarding hernias that we might want to know about in hopes that we can actually improve our patient outcomes. And these are 6 that I put together. Do patients need bowel preps? Do we want to use retromuscular drains? What about a chlorhexidine bath or wipe at home the night before? Is there a good way to reduce admissions? How about epidural use? And again, the question of the robot. And these are all things that can improve outcomes, but again, potentially reduce costs if they have a positive impact. The problem is that you probably need a good registry to collect this data. And unless you have the benefit of being from Europe, where there are excellent national registries, there are not many options here in the United States. Fortunately, there is the America's Hernia Society Quality Collaborative. I would hope that anybody here who's sees themselves as a hernia surgeon is at least familiar with this, and if you are, I would hope you might join. If you're not familiar with it, I'll talk a little bit more about it here very quickly. It is a registry with prospectively collected data and standardized definitions. You collect patient demographics as well as preoperative information. You, the surgeon, then put in your operative details, and when the patient comes back to see you at roughly a 30-day follow-up, you gather data there, and they also get a quality of life form. The AHSQC then helps you out by administering follow-up at 6 months and then yearly thereafter using whether the patient comes to see you in clinic or an email or a phone call to gather data down the road. The good part of this is that it can help identify high-performing sites and best practices, and once those are identified, you can take those home and potentially apply them to your practice as well. It is free to participate, although you do have to be a member of the AHS, which is about $160 a year, not too bad, and it does fulfill Part 4 of your ABS mock. So just quickly going back to those 6 questions, and I'll be wrapping up here, is can we use the HSQC to answer any of these questions? And as a matter of fact, we already have. So we actually found that when you use bowel preparations, it tends to increase your 30-day SSI and SSO rate. I certainly at Vanderbilt, we've gotten completely away from using bowel preps except in very extreme circumstances where you need completely decompressed bowel. Retromuscular drains are okay to use. They do not increase SSIs or SSOs in this patient population, and they may help prevent seromas. Pre-hospital chlorhexidine scrubs actually also increase the rate of 30-day wound events, and we've gotten away from using those as well. Again, these are maybe not the most expected findings, but the HSQC now has over 30,000 patients enrolled, and I think that there's really good power to a lot of these studies. Admission, and this is a paper in press right now, admission of a post-discharge standard questionnaire or an early clinic visit can help reduce your patient's readmissions. Also, epidurals tend to actually slightly increase your length of stay, especially when compared to the use of a muscular neuroblockade such as a tap block, and that's something to reconsider. And then you might want to consider a robotic approach if you have appropriate training and the appropriate patient. So in conclusion, I think that there are lots of ways to add value to your hernia repair. I'm not saying that everybody's here is going to suddenly go home and start doing fancy robotic repairs like you might see some of the videos here. On the other hand, if you're currently using epidurals, you might consider not using an epidural, and you could reduce your length of stay that way. Likewise, you can make intelligent choices about your mesh and where you place that mesh. You can also implement or stop using things like bowel preps and chlorhexidine. These are all things that you can do to, right now, today, take control and do this for your patients so that you increase your quality and your outcomes, you decrease your cost, and bring real value to your patient population. Thanks very much.